Great. Well, welcome again, everybody, to today's webinar. So we're going to be talking about advancing cognitive care from validation to cultural adaptation, highlighting two of the abstracts that BrainCheck had the privilege of presenting at AAIC this year. Before we kick things off, just going over a couple of housekeeping items. Today's session will be about 30 minutes long. It will be recorded, and we'll be distributing the recording to all of our attendees as soon as possible. And additionally, all of the attendee mics are going to be muted for the duration of the session. If you have any comments or questions as we review some of the data, please feel free to add questions to the chat box, and then we'll have about 10 minutes at the end to go over any questions. Okay. So today we're going to be really focusing on connecting the dots between clinical validation, real world workflows, and the equitable access of digital cognitive assessments through linguistic adaptations. And we can go to the speakers. Yeah, so just to introduce myself and my colleague, Bean. My name is Mary Patterson. I oversee clinical operations and compliance for BrainCheck and care implementation. Bean?
Yeah, hi everyone. I'm Bing Huang, so the principal scientist at BrainCheck. So I work closely with Mary in the clinical team. So I conduct research at BrainCheck to develop and validate the digital tools. Back to you, Mary.
Great. Do next slide. So yeah, just to kind of reframe, our three main goals today are to summarize the validation of our digital tests based off of some recent data, specifically looking at test-retest reliability and our concurrent validation with standard pen and paper neuropsychological testing. Share the progress on our cultural and linguistic adaptation, specifically through review of our Simplified Chinese feasibility study, and then discuss a little bit more broadly equity and the broader impact for earlier and more accessible detection in this space. So just to give kind of an overview of BrainCheck's platform, we are a clinically validated FDA Class 2 software platform that digitizes cognitive assessments from end to end. So we have a screener at the front end of the solution that is 3 to 5 minutes, moving into Assess, which is the FDA Class 2 regulated medical device. And then at the other end, we do have a smart care plan available as well. So we support in-office or remote use on any device, really to optimize early detection, deliver those personalized care plans, and support reimbursement pathways. We also have 18 additional screeners that are available for deployment and support EHR integrations as well. So before diving into the concurrent validation data and test-retest reliability, I wanted to just highlight the importance of early detection specifically, and the burden of undetected cognitive impairment specifically in primary care. Current data suggests that about 50 to 60% of cognitive impairment is currently going undetected in the primary care space. And so digital solutions like BrainCheck help by being repeatable, which is some of the key data we'll talk about today, scalable and efficient. And our previous validation work that has been published and we highlight often on our website and marketing materials is BrainCheck's proven ability to distinguish between those that are cognitively unimpaired, those with dementia, and those with MCI. And so today, again, we're going to be looking at the reliability of BrainCheck Assess and the concurrent validity against neuropsychological testing. So this data set was collected in partnership with BrainBox Solutions. We had about 521 cognitively healthy adults to start with, and then two subsets of data. The first being test-retest reliability, and that had a cohort of 60. And then the concurrent validity had a group of 68 that we were able to analyze. And we did this by looking at each of the cognitive domains covered by BrainCheck Assess. So that includes immediate and delayed memory, attention, cognitive flexibility, executive function, and processing speed, and then matching the assessments from BrainCheck with their traditional neuropsych test, so the exact duplication on paper. Okay, perfect. So the results from the retest reliability analysis indicated moderate to excellent reliability overall. BrainCheck Assess scored the interclass correlation was 0.88, again supporting that consistent performance over time. Notably, we did observe practice effects, which is common and was expected. But for recognition memory specifically, the inclusion of response time improved the reliability observed, and that helps capture very clearly how digital solutions, by capturing speed, can reveal nuanced performance differences beyond accuracy alone. And then as far as the concurrent validity in comparison to standard neuropsychological testing, we saw moderate to high correlations with their paper-based test counterparts. The convergence validity was strongest for delayed memory and cognitive flexibility for the digit symbol substitution, being very highly consistent with the WAIS processing speed measures. And so when taken together, we really felt that this data highlights why BrainCheck measures the same as the neuropsychological test counterparts that we're often compared against. We wanted to take this opportunity to also highlight some of the recent validation work beyond what was shared at AAIC that BrainCheck has accomplished over the past couple of months in terms of our comparison to known neuropsychological testing and standards specifically within primary care. And so when you look at Assess's performance against MoCA, we see a correlation coefficient of 0.77, a high level of agreement there. And that is one of the items that we're working on is developing a crosswalk tool for our providers to compare what the BrainCheck Assess score is, what that counterpart would be on MoCA to help with interpretation and subsequent diagnosis. And then the SLUMS data that we have is really exciting because of the sample size we were able to achieve here. This analysis looked at individuals that had BrainCheck Assess administered on the same day as the digital SLUMS. And so this is real world data in a single test time point and a sample size over 2,000. And again, you see a very high correlation coefficient and agreement between the two tests. And we're hopeful to be able to further validate this by bringing on additional sites and current customers to share real world data with us so that we can continue to develop and understand the real world application and clinical utility of our tools. I'll pass to Bean.
Yeah, so I want to share one of our recent projects to adapt to the BrainCheck Assess and for other culture and language. So currently BrainCheck is available in English and Spanish. But if you look at the US population, so the Chinese American has been one of the fast growing kind of population over the past few decades, increasing from like 4 million to 6.1 million. And 14% of them is 65 years older, place them in a higher, a risk category, like for developing dementia. Most of them, they are first generation immigrants and with limited English proficiency. And this language barrier has created the challenge for them to accessing like a health service, including the cognitive care. So there are data showing that in California, so Asian Americans are significantly less likely to receive like a timely diagnosis of dementia or comprehensive kind of assessment. So Chinese American is the largest kind of subgroup among the Asian Americans. So currently there are kind of traditional paper-based tools like MoCA or Minimental have been translated for this population. However, this tool has several kind of limitations. So they do require like in-person administrations. And for this population, it also requires bilingual kind of providers, which is kind of currently in shortage. These assessments are also not reimbursable, and some of them lack the sufficient normative database for appropriate kind of scoring. So we see a clear need for culturally and linguistically adapted cognitive testing tools, and for this population, especially our digital cognitive testing tools that are easy to use and scalable, so it can be adopted by more kind of providers, and ultimately, eventually kind of like increase the access to the cognitive testing. So we conduct a pilot study here to explore whether it is feasible or not to adopt BrainCheck Assess into Chinese version. So we hired two independent bilingual kind of like translators to translate the BrainCheck Assess into simplified Chinese version. This is direct translation without any kind of adaptations. And then we conduct our cognitive interview studies. So where the participants complete the BrainCheck Assess in person on an iPad in front of our research assistant. Participants are encouraged to verbalize their feedback in real time. And afterwards, we conducted interviews to gather the overall kind of experience. We recruited 5 cognitive healthy kind of participants from our local Chinese American community here in Austin, Texas. So the participants range from age from 60 to 73, have a good balance in terms of gender and English proficiency and the type of the Chinese language they spoke. In general, their education level was relatively high. All of them have college degrees. So the funding from this pilot is very helpful. First, we found that once participants understood the instructions, all of them were able to complete the entire kind of BrainCheck Assess, even the one participant who have very limited kind of English proficiencies. So we also saw like the participants who are more familiar with the traditional Chinese had no problem complete these simplified Chinese versions, which was very encouraging. Participants also report high usabilities. They rate like 1.6 out of the 5, like 1 means that very easy to use. Also, at the same time, we identify a few areas that need additional work. So for example, some instruction was not clear and required culture adaptations. And also all of the participants agree that choice making kind of B assessment was the most challenging task for Chinese American populations. This task required, clicking on the dots in an alternative sequence between the number and letters, like 1A, 2B, and 3C. But in Chinese language systems, there was no such letters. So this type of task isn't familiar like at all for the native Chinese speakers. So overall, I think the results have from this kind of small kind of pilot study suggest that it's feasible to adapt Chinese BrainCheck Assess into Chinese version, but clearly there's further work is needed. So for the next step, so we're going to carry out culture adaptation by working directly with the old Chinese speaking old adults. We will also collect a dedicated kind of like a normative data set and also work to validate the test performance in these populations. So we also have additional language version of of BrainCheck Assess currently under development. So for example, the Russian version is now in validation phase. So we have already collected 100 data points. So we will start the analysis process, and we're expecting this version will be ready for use probably early next year. So in addition, we are part of the large European cohort study called Predicton, which will enroll like 4,000 participants over the next few years. This study will involve like 5 major languages right now across the European. The next step for the Mandarin kind of version will be moving into the validation phase as well. So we also regularly receive requests from our clients to develop new versions into the other language, such as Hindi, Korean, Polish, and Arabic. So if you are working with a specific kind of like population and you are interested in collaborating to develop a culture-adapted version of Chinese BrainCheck Assess, and for that group, please feel free to reach out, and we'd happy to discuss how we might work together. So I'll stop here and pass back to Mary.
Great. One of the key ways that we expand our clinical profile and the validation of tools like BrainCheck from the use of screen, assess, and care plan is through partnership with academic institutes and universities. And so want to highlight the work that we're doing in this space in third-party validations and the broad range of specialty types and research covered here. We are most excited and interested in research in the cognitive space, but I think that the data here shows that BrainCheck has applications in various settings, and we're actively working on expanding evidence across populations and multiple different care pathways through these third-party collaborations. Fine. We also wanted to take the opportunity to highlight our own internal BrainCheck pilot grant program. So if you are exploring research in the Alzheimer's disease evaluation space, diagnosis, treatment, or care, please do consider our BrainCheck pilot grant. So applications are accepted on a rolling basis. And we'll fund up to 2 pilot projects per year with a total of $10,000 allotment for each of those applications. And so if this is research in a space that you're actively working in, please do consider reaching out and applying through the links included here. And this is also available on the BrainCheck website. And so just to summarize before jumping into the Q&A session, I think the most important takeaways here is that we feel strongly that we are able to demonstrate BrainCheck Assess's clinical validation and its reliability and validity versus traditional tests. It is a practical and most notably scalable digital solution enabling rapid, repeatable testing. And that in terms of cultural adaptation, direct translation isn't enough. Context is incredibly important. And so we're doing that work and for a number of different translations and are dedicated to doing so and making testing more accessible to a broad range of populations. And that'll be on our clinical development roadmap over the next year to 2 years. And our dedication to equity in care, validation and adaptation supports fair and accessible early detection, which is what BrainCheck is most passionate about.